educational executive committee. So I'm going to convene today's program. Thank you everybody for joining. I'm just going to present a few slides by Servier. The Servier is a sponsor for this program in terms of logistics. And as we know, Serdia, it says the brands all which are available here is the Daphlon. And there are ingredients which are not procured from China, they're all from France. And Serdia has really helped Venous Association of India in spreading the awareness about venous disease in the country from last so many years. And the latest initiative, what we have is we nearly 50,000 people has been reached, and there are a lot of videos which has been recorded, and they are being regularly put up. And I think in another 1 to 2 years, we will have around 5 to 10 lakh people reached from that page, and then we actually do a huge amount of venous awareness programs from there. Thank you, everybody, for that. And I think coming soon, as you know, there will be more people who will be joining in there. And so, if you want to put in up your videos, please record videos and put there. The plan is there will be two speakers, very, very eminent speakers in their field. I will introduce them, view them very shortly. So this is a program which is going to be run for 1 hour. First of all, I'd like to introduce my friend from Delphi, Swat, and he's a vascular surgeon. He's one of the first professors of venous disease in a university. And thank you, Dr. Swat, for joining us and giving us your experience. And for people who wants to learn iliac stenting, he runs a training program. So I think once COVID goes off, and people who are interested in going there, please, you can contact Dr. Swat or VI, so we can facilitate for you to go to him and learn some tips. Dr. Robbie George, we know him from so many years, very close friend again. Thank you, Rob, for joining up at a very short notice. He's a vascular surgeon, head of the department there in Bangalore, and he's going to showcase two cases of iliac interventions, and both the speakers have got immense experience in the field. Dr. Rashid Bishara from vascular surgeon, he's a vascular surgeon from Egypt, another very close friend of VI, and he's the head of the department, and he's got a lot of experience in iliac interventions, and will be, very enriched with his inputs, what all things not to be done. Dr. Fabrizio, vascular surgeon from Brazil, and thank you for joining here with us, and with Dr. Rashid, and ask some lot of questions, from the speakers, and by which we'll all be enriched. Dr. Tarun Grover, a very, very close friend, very old friend, and he's co-director of Medanta, one of the biggest hospitals in the country. He's a vascular surgeon, and he does a lot of iliac interventions. So he's on the panel, and I'm sure he will put in so much light on all the questions, and with his experience, what he has. So this is the program what we have, and just to remind you, next Wednesday we got a very interesting program. It's all cardiothoracic, and because as a vascular surgeon we are slightly away from this, but I think sometimes if you're doing the intervention, if you have if you're there and the clot goes into the pulmonary circulation, then how to get out of it at the same time, because the patient can die when you're doing the interventions. So we got all endovascular management of pulmonary embolism. So it's going to be chaired by the cardiac surgeons, cardiologists, vascular surgeons, and please join us next Wednesday to enjoy the show. So thank you here, and I will hand over the mic to both the chairs, Professor Rashid and Professor Fabrizio, for conducting the meeting. And so we got around 20 minutes for Swat and 10 minutes for Robin, and then we'll take up the questions. Please put the questions in the chat. So we will not go by speaking. So from the chat, the questions will be picked up by the chairpersons, and they will put these questions to the speakers. So thank you, and I'll hand over the mic, Fabrizio and Rashid, to you.
Okay. Good morning from me here in Brazil. Thanks, Ravu, for the kind invitation, and Venous Association of India in name of the Brazilian Society for Vascular Surgery as well. And I think I'm going to Professor Rashad is still coming. I think he's online, but let's go to Professor Swat Togansi in its talk, and then after that, for the case presentation, can we start? Swat, are you ready?
Yes, I'm ready. And thank you for the introduction. And also, I want to thank.
Sorry, just a moment. I'm just going to mute everyone now. So you can unmute and you can start then.
Okay. Don't you hear me?
Yeah, we can hear you.
Okay. Because I am.
Please unmute yourself, please.
Okay.
Yeah, fine. Fine. Yeah.
Okay.
Swat, you can share your screen now. Yeah.
Yes, I am doing now.
Yeah. Thank you.
Perfect.
And first of all, I want to thank also Rahul as my dear friend, and to why to organize such a meeting and for inviting me to give such a lecture on deep venous stenting. So in this issue, I'm going to talk about for both post-thrombotic syndrome and compression syndrome stenting. And I want to highlight a lot of conflicting points. So as I heard that I will have a lot of questions, so I'm trying to highlight a lot of questionable points regarding with iliac stenting. First, I just want to talk about some issues about compression syndrome. So the most less we know is the May-Turner and Nutcracker syndrome. So I don't want to go to talk about what is this compression syndrome, but I just want to highlight what is the diagnostic criteria for May-Turner syndrome. Is just 50% lumen reduction is enough to talk about May-Turner, or more than, let's say, less than 0.4 centimeter square surface area reduction is enough? And which diagnostic tool we should use? Is it duplex, MRV, CT venography, IVUS, or should we count on venography findings such as the collateral venous circulation, contrast stagnation within common iliac vein, contralateral cross-feeding, balloon testing, IVUS findings, so more than 50% lumen narrowing with the common iliac vein, or extensive intravascular webs. So these are all questionable issues that we should answer to put a stent for a May-Turner patient. And just when we came to the question Nutcracker syndrome, so we know this disease nearly from 1937, and it was named by Nutcracker in 1972. When we look at the etiology, there are two main forms of Nutcracker syndrome, anterior and Nutcracker. So we know all these issues. And there are also a lot of common pathologies that can cause to Nutcracker syndrome. And we know there are also some rare indications. And when we look at the clinical features of the Nutcracker syndrome, which may include pelvic pain, flank pain, hematuria, gonadal varices reflecting pelvic and renal congestion, and orthostatic proteinuria. So these are all known issues, but which signs and symptoms are indicative or definitive for Nutcracker syndrome or May-Turner syndrome, such as pain, swelling, venous claudications, pelvic congestion symptoms. So we know all these can happen in those patients, but when we come to which patient we should treat, there are again lots of questions. And also the diagnosis. We know that we have a lot of diagnostic tools that we can choose, but however, the diagnosis still can be challenging to confirm based on solely on imaging, because presenting clinical signs and symptoms are therefore, it's more important than the images themselves. I want to show this article, which is a part of our group from Maastricht, that they make a study on asymptomatic ladies to find some definitive criteria. But at the result of study, they found that nearly, let's say, 16 of the participants and 80% of this, let's say, group had some parts of compression, some parts of collaterals, and then nearly many of them has the signs of May-Turner syndrome. And as a result, they sent these images to some surgeons who make these procedures, and many of them say that I can stent those patients. So should we stent asymptomatic patients for just sake of some images? And as a result, they say that treating the patients rather than the image seems to be a valid principle. So this is very important, just not to stent images. And I want to show you some duplex images, which is done on supine positions and the upright positions. When you look at now, you see, especially for this moment, this is an upright position. We don't see any compression, but when we put the patients on supine position, we observe some compression. So this is a dynamic situation. Therefore, we have to make some dynamic imaging. So this is also another patient. When you see it in the supine position, we have some type of compression, but when we put the patient up, we see that the compression is relaxed position. So how we will decide? And this is a sample of Nutcracker patient. As you see, when we put the patient on an upright position, the compression is removing. But when the patient on his spine position, we observe this, let's say, compressed situation. So how we will decide what to do? Those are all very conflicting results. And this is the image from the, let's say, axial view. We see that the compression is just not going away when we put the patient up, and it is still compressed when the patient is in supine position. So these are all conflicting points. When we came to the post-thrombotic syndrome part, it is much more clear than the compression part, because we have some, let's say, maybe accepted indications. Again, I want to start with, should we stent every post-thrombotic patient? From my point of view, it is no, as the answer is, because for the asymptomatic patients, I think there is no need to make such type of extensive procedures, because from my philosophy, if you make a therapy to a patient, the patient should observe a difference in his quality of life. So for asymptomatic patients, I think we don't need to stent. But if the patient has medications, if the patient has a venous ulcer and low quality of life scores, then I think those patients should be stented. And as we know, we have two different way of stenting: solely percutaneous intervention and hybrid procedure, which we combine with surgery. But the decision making which patients should go percutaneous and which patients should go hybrid, it's also a very subjective point, and it is difficult to answer. So we know this classification from Dr. Human Celal, which is now on the validation study has been completed and almost ready to be submitted to the journal. So as this classification, we have 5 classifications. The first one is the non-thrombotic, and the other group is post-thrombotic patients. And when we look at the class 5, it is accepted as contraindication because all inflow vessels are involved. But we can still, we know that from Dr. Garcia's study, Access PTS, maybe with Access PTS, we can give some chance to this group of patients. So we will have the results soon, and I'm happy also to be involved in this project. So it will be a good, maybe especially for the new beginners to make as a guide. So what we do for percutaneous stenting, we have a puncture of the femoral vein or sometimes the deep femoral vein. And so we know the principle that we should stent from healthy to healthy segment. So we should put our tip of the sheet beneath the disease segment. This is important, otherwise you cannot deploy your stent into the healthy segment. And it is sometimes even very difficult because at the femoral part, the artery and the vein is superposed on each other. So we should be very, let's say, experienced also in duplex ultrasound to find a puncture point to make an insertion to the vein. And after, I think if you pass this first stent, then I think another difficult part is the passing through the disease segment with your hydrophilic guide wire. and some support catheters. And this is the most important part of the procedure. I call it just like walking in a maze, because you don't see wherever you are going, and there are a lot of endless points, and it doesn't give you a chance to just go through the internal inferior cava vein. So it can take some long hours. From my practice, I know that nearly I deal with 5 hours just to pass through this disease segment. So I think you should be very, very patient, and also you should be prepared for internal jugular vein, let's say, access. And then you, of course, you have to have some snares in your armamentarium in the OR. And predilatation is the next step. This is very important. You should never stand without predilatation, because you can never open your stent until the desired diameter without predilatation. Then we put the stents, and we know the sizes from Dr. Raju's article. So we have some larger diameter stents, which is offered for the cava and the iliac part. And post-dilatation is also very important. We know that these are very highly restricted and very fibrotic vessels. Your stent never opens enough if you don't make post-dilatation. And for the hybrid part, we have the surgical part. We are adding the surgical part. We make the endophlebectomy and patchplasty and AVF fistula formation. So we prepare both the artery and the vein, and then we open up the vein and we clear inside. As you see here, these are all type 3 or type 4 collagens. So this is nothing related with thrombus. You just have to clean up inside the vessels like this. And the most important, one of the most important issue is you should open the orifice of deep femoral vein, because in most situations, the deep femoral vein is becoming the main inflow vessel. So these are all important steps. And after this, we are making the AVF formation. And this U-shape or loop shape AVF fistula configuration is also belongs to Dr. Human Jerai. So he published this article. If you make such type of, let's say, AVF fistula, you are just make a resistant to your inflow, and you shouldn't do it in such way. And then we make this AVF fistula with 6 millimeter PTF ring clefts, and then in several times later, mostly it says that you should do it after 6 weeks, but this is highly discussive point, because in some situations when you close your fistula, you lose also stent. So it is very important. You come from the contralateral femoral artery and you just go in a stent and put an unplug, let's say plug occluder, and you close the AVF fistula in a percutaneous way. But in my practice now, I nearly don't close the AVF fistula if the patient doesn't have any fistula related complication, because nearly half of the patient is we are losing the stent, and this is discussive point we can discuss later on. And post-stent care is important. We have to immobilize the patient as soon as possible. Sometimes for the hybrid cases, it is difficult to mobilize, so we have to use some pneumatic compression devices or such type of neuromuscular activation devices. These are all important, and we have to make some duplex control after the procedure, before the discharge, and at the second week of the discharge, because if we have an early thrombus, we can catch it and we can recanalize it again. And anticoagulation is very important and is very, again, highly discussive point. And we know from the Dr. Alan Davis group that there are a lot of different protocols for anticoagulation, but in this Delphi document, we know that the anticoagulation is preferable, and sometimes we can add antiplatelet therapies for the therapy, and especially for the May-Turner group, you can, let's say, stop your anticoagulation after 6 months, but for the post-thrombotic group, if the patient has also thrombophilia, you can continue maybe lifelong anticoagulation following venous stenting. And I want to put some discussion points and conclusion, because venous stenting in both indications has good and reasonable long-term results and impact good enough for the patient's quality of life. However, for the compression syndrome, we are depending too much on supine imaging modalities. Therefore, we should really train or be trained to image people in an upright position as images of suggested compression disappear. And we should always treat the 4 months complaints, not the images. And we should have validated and dedicated questionnaires, because most of the time we are using the Villalta scale, but this scale is not a perfect scale, as we all agree on it. So we should, I think, include the venous claudication as an let's say one of parameters in some questions. And when we come to the indications of therapy for compression syndrome, I think first we should answer those questions. What is real compression? What is definitive criteria? What is the definitive symptoms? So these are all important questions, because we should avoid unnecessary stenting, because we don't know, nobody knows any stent stays open forever. And if we just stent for a mid-donor patient, and if it is occluded, then I think it is the worst thing that you do for the patients. Here is some examples. For example, this is examples of post Nutcracker syndrome. Here we see that some ultrasound images, and this is a case from me that I made recently. This was a complication of glue therapy for a varicose vein that was done 1 year ago in another center. So I stented this patient, although it is a bit difficult, since this is not only a simple thrombus, it's a complication of glue. And I could hardly predilate and stent those patients, and the result looks good for this patient. And this was the that I also balloon dilatation for the femoral part of this patient. And so I also tried to open up the femoral vein as much as possible, and the inflow, especially after the predilatation of the femoral vein, also on this part, you see it is nice. And this is an example of extensive iliocaval occlusion of the patient. Here you see that there is almost nothing but the collaterals, but after stenting, the final phlebography is, I think, reasonably good. And this is another example, again, for an iliocaval occlusion. So here we see that there is only the paravertebral collaterals, but we don't see any thing related with cava and the iliac veins. I could hardly pass through these iliac lesions. And for the especially iliocaval stenting, you should always park your wires up enough of the heart, because if you have a stent jump, you can still get it back with balloons if you have your wires so high. Otherwise, you can have real problems. And we start from very small balloons and go up. So these are very important steps. And then we stent the patient. See, this is the final result of this patient. And these are all wall stents. And this was the, let's say, wound of the patient before the procedure. And this is only, let's say, 4 weeks later. And this is also a very rare case, I think, to stent indication. This was an retroperitoneal fibrosis case. I just could hardly stent the right side, and I couldn't pass through from the left side, but the patient benefit also for the left side, because this patient has lost his ovaries, lost one of his kidney because of the retroperitoneal fibrosis, and also he lost his central veins, and she was experiencing huge edema. As you see, there is almost nothing. We can accept maybe this as a chronic deep vein thrombosis patient, although it is not. And I could hardly pass through it. And as you see, this is after predilatation, and these 2 images after, let's say, stenting. This lady benefit for both legs now, and she is really happy, and she doesn't want any extra procedure for the left side. But if she has some complaints, come back for the left side, maybe I can try also the left part. And Thank you for listening. I hope we can do the next year, the World Congress for the International Union of Phlebology. But I just want to invite all of you to participate the next World Congress. And thank you for listening.
Thank you very much, Swat. I just want to remind you all that in the bottom of your screen, you have a chat box where you can insert your questions. And I ask you please to write them so that we can tell them to the speakers. And I hope you collaborate because we won't have the possibility of performing live questions, okay? So I hope everybody can make their questions. So now I think that now we're going to the other presentation from the case presentation from Dr. Robbie George. And after the case presentation, I think we can make the questions and open the questions for the panelists and also for the attendees, okay? Robbie, are you ready?
Yeah, I am ready. Thank you, Fabrizio. And I must say that was a really masterful talk on whatever are the concerns as far as deep venous interventions goes. So that makes my life a lot easier. So I'm just going to be looking at two cases here. Can you see my slides?
Yes.
Yeah. Okay. So two cases here, one of a compression syndrome and one of post-thrombotic syndrome. I'm going to keep this more as a step-by-step kind of thing so that for those who are not familiar with it, it's hopefully going to be useful for them as well. So the first is of a lady who's 38 years old, right leg pain, heaviness, C4A, C4B disease, no superficial reflux. So as Swat said, we are very careful about whom we offer an intervention to. It is not for minor disease. You need to have earned it before we will think of doing a deep vein intervention. So we did a venogram here for her. And as you can see, this is on the right side. There appears to be something maybe happening right at the point of the IVC confluence with the iliac vein. So is this a right-sided proximal NIVL is the question. So this is in the time more recent when we had IVUS available. So we chose to do an IVUS here, and that's just the IVUS catheter pulling back. And you look at the IVUS higher up as well. So when you do an IVUS, you start from the heart and you pull your way down to see what is happening. So this was the IVUS run, and as you can see, the IVC there, the iliac veins just being about to come off. And there you begin to see the compression starting. This whole area is flattened, continues to stay flattened by the artery that's crossing it there. And it's a fairly long segment before it opens out again into healthy vein over there. So this confirmed the diagnosis of May-Turner syndrome, which was not that obvious on the venogram. And we had taken venograms in multiple planes. And this was on the background of her having significant clinical symptoms. So we don't use any of these in isolation. They're all used in combination to make a diagnosis. So when you do your IVUS, you get these measurements, which shows you what's the maximum area, what's the minimum diameter, what's the maximum diameter, which helps you to choose the kind of stent size that you would use. So here it's a 19.4 we're seeing maximum diameter with a significant area reduction. So this is when we do a pre-balloon, and this is also a technique you can use for diagnosing May-Turner, which is by doing a trial ballooning. And this actually opens up quite well. You're not seeing a very tight lesion, but there is a bit of a waist over there, not very convincing though. But given the clinical context, given what the IVUS showed, we were happy that we need to treat this, and she was treated with a 2090 wall stent, and she did very well after that. At the end of this, we do an IVUS again through the stent to see whether we've got it right. And here you can see the proximal IVC, and there the stent struts are coming into place. And you see the stent is fully opposed to the wall of the iliac vein, which means it's an adequate stent that is appropriately sized. So that was case one, May-Turner syndrome, which is a relatively easier deep venous intervention to do. And as Dr. Swat said, this other patient, case two, is I think a 46-year-old gentleman who had come with a left-sided venous ulcer, history of a DVT, a post-thrombotic syndrome. Keep aside enough time on your operating list to deal with this. So first venogram. And so this is talking of so we started doing deep vein work in about 2011. And this was done at a time when we did not have IVUS. So I particularly picked this case so that for those of us who don't have IVUS, there's some things that we can learn here. So at that time, we were puncturing the femoral vein, but we would always in these cases do a puncture on both sides so that we can see what is happening with the IVC and the iliac confluence. So as you can see in this, it is an iliac vein occlusion. And the common femoral vein itself does not look great either. There are big collaterals. And we managed to cross it, get a wire through that, which is always a hard thing to do. But once you're through, that's the first step. And as Dr. Swart said, pre-dilate with small balloons, pre-dilate the whole way up, and we are pre-dilated down. Now, if you note, this wire is now crossing down below. So what we had done, the same as Dr. Swart was doing, we have taken an IJV puncture, snared the wire, and now we are working from the top down and from bottom up both. So you need to be able to do this, and we've negotiated this wire into the femoral vein distally, the deep femoral vein, so that we can establish inflow, which is one of the most important things in deep venous intervention. If you do not have your inflow sorted, your stent will shut down. So this is the image we are seeing post-plasty. It has opened up, not opened up very well at all. And do note how this wire runs differently from the course of that collateral. So it's very easy to get misled by a collateral and think that is the native iliac vein. So at that time, we were using the stents which were available. So we've deployed one at the top here. We're obviously not happy with that. That's not enough. So we've deployed a second stent down below, and we are now doing a stent balloon. You can see how little the stent has opened. So post-thrombotic syndrome, no stent will open enough. You need to do a post-deployment plasty. And if you look at this, again, we are plastying out here, down below. Now, if you note this angiogram, we have passed a catheter and we are injecting from below. So we want to see the direction of flow going up. So are we getting adequate drainage is what we're looking for. So there is much better drainage than there was before, but there are still collaterals that are flying, not entirely happy that we have got an adequate inflow restored here. Look at it in a different projection, still not happy. So we go ahead and we plasty further. And if you look at this balloon, you see this tight waist coming up at the inflow point. So this is the kind of patient who would be suitable for what is called an endovenectomy or an endophlebectomy. And we've done a fair few of those, but they are slightly messy operations also if you don't always jump into them. And at the end of this, the stent is opened up. And I must say the stent that we were using was a wall stent down below, and it's a larger diameter. Nitinol stent is what we had used at that time. It looks pretty horrible when you look at it in this AP projection. We looked at it in a left anterior oblique projection, and you can see the course of the iliac vein. It is actually a lot of curves over there that it takes. And this is what the stent has to go through. So this is when we get the patient to flex the leg. Sorry, it's in the next image here. With flexion at the hip joint, you can see how the stent has to move to literally 90 degrees to cope with that. So this gentleman also did very well. And that's been our experience, that deep venous stenting for PTS, for May-Turner syndrome really works. For PTS, they stay open for a while, but not all of them stay open forever. And that is something to keep in mind. So a PTS patient, you have to make sure that you've got a good indication before you decide to intervene. There is a fair amount of hardware you will use to get any kind of results. And often these stents will not stay open forever. Thank you.
Okay, thank you, Robbie. Professor Rashad, please.
Yeah. Well, thank you very much, Rahul, for inviting me. It's a real pleasure and honor. I'm sorry I was a few minutes late. And I have a few questions for Siwat. Siwat, of course, is a very experienced operator, and thank you very much for sharing with us your great experience. I have, a couple of questions. First, about the May-Turner syndrome. when you have a patient coming to you with unilateral leg edema and you do venogram and a duplex and you find iliac vein stenosis and you're happy with the diagnosis of May-Turner and you go ahead and put a stent, how many of those patients you expect to be relieved of their symptoms?
Dr. Rashad, thank you for the question. I think these are for me, the most difficult cases to decide to put a stent, because from my side, only just leg edema is not an indication for stenting. As long as there should some other symptoms for the patients, especially for the May-Turner syndrome. And I always do some dynamic imaging, because I don't just trust on the CT venography or whatever it is. I always do dynamic duplex imaging by myself, and if I see any fixed compression even during upright position, I just sometimes, if the patient has some real complaints other than edema, I decide to stent, and otherwise I just keep watch those patients or follow these patients, and if I stent let's say that I believe from my point of view it's a real May-Turner, all those patients really benefits from those procedures. But this is very difficult question to answer.
Yeah, I agree with you, because I've seen some of those patients who were stented for unilateral edema, and the edema stayed the same because it was lymphedema. So I totally agree with you. Another question: if you have a patient coming in with, again, unilateral leg edema, and they have varicose veins and serious, May-Turner syndrome, like iliac vein compression, which would you treat first, or which would you treat?
Actually, Dr. Rashad, you are asking really good questions. So I know what is your opinion about this, but again, from my point of view, his symptoms is the first thing to treat. If the patient is coming, let's say, for us with the leg symptoms, and the varicosities, I think, is let's say, the first or the most severe symptoms of these patients, I still don't put a stent. I just treat the varicose vein. If the patient's if the patient doesn't have a real fixed compression, I just treat the varicose vein, follow the patients, and then according to his complaints, I put a stent. Normally, you should say that maybe first treat the compression, but if I don't feel that it is not a real compression, I never stent first.
Yeah, thank you very much. Can I ask you more, Fabricio?
Actually, Ravu told me that we need to do just 2 questions for each panelist because of the time. So I don't know, but probably we'll have time for more questions. But you can make questions, Ravu.
We can finish off one round. So like you can ask question, then Tarun can ask question, and then if we don't have questions in the chat, then you guys can carry on.
Yes, totally agree. Yes.
Got plenty of time. Yeah.
So Professor Rashad, you can make questions. I think we also have a panelist with us. So you can make questions for Dr. Robbie. And after that, I'm going to make my questions and I'm going to put the mic for our panelists, okay?
Okay.
Are we agreed, Ravu?
Yeah. Robbie, excellent presentation. Very nice 2 cases. I enjoyed watching them. The second case, you used multiple stents. Is that because, long stents were not available, or is this your choice?
So we used 2 stents, and at that time we did not have the 200 centimeter length stents anyway. But typically, if you're going from the common femoral vein to the IVC, I think 1 stent falls short probably. And but at that time, it had to be 2 stents if at all.
Okay. So let's move to the panelists, maybe.
Yes, but I want to make 2 questions, and I'm seizing the situation for Robbie. He has his mic open. So Robbie, do you consider any situation crossing downstream the inguinal ligament with the stent or no? Or depends on if it's metallic or not?
So yes, no, we do consider crossing downstream the inguinal ligament. We've done quite a bit of that in the early days. But honestly speaking, the way PTS behaves in the long term, even after a deep vein intervention, I've become much more cautious about intervening in PTS. And in India, well, like it's just, I'm quite sure similar to maybe Brazil and elsewhere, where it's a patient pays out of pocket model. You know, you're going to end up using a lot of fairly expensive hardware for a result which is not always sustained for so long. So I'm very cautious about that. And I think if I were in today's time to use a stent going across the inguinal ligament, I would want to use only a dedicated venous stent.
Okay.
Our previous experience was really with the wall stent.
Okay, very nice.
And maybe I can also give a short answer.
Yes, please.
In my many cases, because I am coming across with the GELI classification 4A, 4B, and many of them has extensive disease, and nearly all the time I come down below the inguinal ligament, nearly to the level of confluence of the femoral. And in Turkey, because of the reimbursement situation, I am not able to use the dedicated stents. In many cases, I am using wall stent, and even wall stent, I am coming below the inguinal ligament. So far, I didn't see any fracture with the wall stent, but of course, patients sometimes feel some pain in the inguinal area because of the stent. But if I had a chance to use a dedicated stent, of course, I should go down the below ligament with the dedicated venous stents, of course.
Can I add in something to that, if I could,
yes.
Fabrizio? I think these are the patients where there really is a role for endophlebectomy or endovenectomy, because you can clear out the common femoral vein, you can clear out the orifice of the profunda vein, and then you can establish an adequate outflow. It is so for the way I do endophlebectomy is that I will always take a mid-thigh puncture. I will want to make sure that I've got a wire that has crossed into the IVC before I would open the groin. I don't want to be in a situation where I don't have a wire through and I open the groin and I can't get past. I think that's a bad place to be in. So that's the policy that I follow.
Okay, and I want to make a question for both of the presenters regarding the acute deep venous thrombosis, because this is something that we haven't addressed yet. So what is your main indications if you indicate treatment only in cases of severe cases, or what is your indication for treating acute venous thrombosis in the proximal segments?
I think if I go first, dear Fabrizio, I think I am one of the most conservative, let's say, interventionists to stand in an acute situation. Because I think if you are using IOS, maybe after just cleaning up in the vein, if you are for sure that you clean up all the vein, all of things is just removed from the vein inside, maybe you can put a stent if the patient has a, let's say, real and a lot of symptoms. But if you are not sure that if you didn't clean up the vein inside of the vein, I think this is one of the worst situations that you put a stent and you make it more thrombogenic when you put the stent. And I think putting just one stent to the, for example, May-Turner point is not enough, because the inflammatory situation just start after the deep vein thrombosis, and the vein become fibrotic in some times later. Maybe it can close your inflow because of the, let's say, constriction of the vein. I think that's why now when you look at the published article, they are putting more than 2 stents nearly. They are coming in the also acute situation, they are nearly coming to the common femoral vein. And that's why they are increasing the, let's say, patency following the stenting in acute situations. But this is very difficult. And from my point of view, I never stent in acute situation. I just follow the patients with anticoagulation. If they are symptom free, I continue, because I just wait for the fibrotic changes. And maybe we don't know if the patients become symptomatic in the follow-up or not. Maybe we will not stent these patients in the chronic situation. That's why I am much more conservative about stenting, but we know the results from the literature. They have good results. Maybe these are right, I am wrong, but this is how I feel about this stenting in acute situation.
The problems with the follow-up that we have only follow-ups until 6 months. We do not have long-term follow-ups. Robbie?
Yeah, Fabrizio, excellent question. So you said I'm very similar to Suat as well. I am also actually very conservative when it comes to DVT. So even for thrombolysis or thrombectomy, I tend to be conservative for the reason that, I mean, the literature certainly talks about PTS, but it talks about PTS as a single basket. Now, a mild PTS is not really a big deal. What is a big deal is a severe PTS. Now, you get venous ulceration, you get severe venous claudication, that is a problem. The risk with thrombolysis is the risk of bleeding, which is not insignificant in some patients. And that's the issue. Anticoagulation has proven to be safe and quite effective for, you would say, nearly 90% of patients. And for the remaining who are not doing well, they are in your follow-up. So they are patients whom I can intervene on in a chronic situation as a chronic PTS at 6 months, 1 year down the line if things are not settling. That being said, young patient, somebody with a really bad, like a phlegmasia kind of situation or a really tense, tight leg, somebody who has got a good, strong trigger factor, who may not have an underlying anatomic lesion, these are patients who will probably do well with a aggressive thrombus removal strategy, especially if they come early. And like Swat, I would be very hesitant to stick in a stent in the early stage. When it's so inflamed, the stent is going to potentially give you a bad result. And definitely no stent unless you've got a really, really good and clean inflow going.
Totally agree with you. We'll pass the mic for Dr. Terman Grovewood. He's with us.
Good evening, everyone, and it's great to hear both the expert speakers. And I do have some differences in my practice, and I would say I have a very low threshold for placing stents during acute DVT, because what we have seen is that with the advent of mechanical thrombectomy devices and with good clearances and having a good study with IVUS, and if we have a good result of a stenosis or a stenosis segment after a balloon plasty, then we are happy with it. But in case if there is a significant recoil, and especially for May Turners, and we do always tend to keep the catheter even after placing the stent also. And we do take a picture, say after a few hours, taking a venogram after a few hours after placing a stent and leaving the multi-hole catheter inside, because as we don't want to leave any thrombus through the struts, which will be thrombogenic. And with the advent of DOACs, putting these patients after an acute stenting on DOACs, so these stents, they have a pretty good reasonable patency rates, because we have seen if you leave a lesion behind, especially a significant stenotic lesion, these patients, they come back for the first follow-up. When they come back, the ilex have thrombosed again. They might not be symptomatic, but because it takes a while to become symptomatic. And you don't want to convert them into a PTS, especially for the young adults who have, and with these dedicated stents like obliquus, where you don't need to jail the contralateral iliac. I would have a low threshold for especially lesions of, I would say something similar to May Turners or a common iliac lesions, which require just a small stent, and you have nicely cleared the whole vein, and so you give them a good result. Only challenge is that these patients, they have to be little, I would say, long-term anticoagulation. We don't know when to stop that, because you do see these patients having stent thrombosis once you stop the anticoagulation. So that's the only, I would say, a long-term challenge. But anyways, if you don't put a stent, they become PTS, then anyways, you will be giving them medication for a lifelong.
Professor Rashad, or any other considerations from the other panelists?
Tarun,
Yes.
any other questions to the speakers? Tarun, any questions to the speakers, please?
I think they have covered everything very nicely, and probably, most of us, we have a similar sort of a practice. And only thing is, what I feel is that we should not generalize that, we should not stent in acute, we should not stent. I think every case has to be evaluated in a single situation, like what are his condition, whether he's a prothrombotic, whether he's thrombophilic, whether we will be able to keep him on a surveillance, whether we will be lost on follow-up. So I think it has to be a lot of other logistic factors also, apart from the disease profile, cost, what his compliance is going to be. Are there any extrinsic thrombogenic factors like extensive smoking, immobilization, obesity? So usually in my practice, I put all these factors into play and then decide what's the best for the patient.
Can I say one thing? So I think one of the reasons I became perhaps extra conservative is, bad experiences. So I've had two patients who come back with a contralateral iliac vein thrombosis. One after a stent that was done for a May-Turner associated acute DVT, which was a provoked DVT, and another chap with a standard May-Turners who had advanced CVI in the leg. But they both came back with a contralateral DVT, and they were all, I mean, they were in their 40s. And, you know, to my mind, I have caused them significant harm compared to what they would have had otherwise. And I think, unlike in the arterial system, I think some of the venous problems turn up later on, you know, at the 3, 4, 5-year mark, or sometimes a little bit sooner. And sometimes we don't see what is happening, but there is, I think, metal inside the veins of young patients for a long time, for, you know, 30, 40, 50 years of their life. I don't really know how it's going to pan out.
Well, I had, if I may, Rahul, I had patients.
One question in the chat also, once you finish this. Yeah.
So I think Professor Rashad can talk, and then after that I'm going to make the question from the attendees. Okay.
Okay, thank you. I had a patient with, or patients with acute urifemoral DVT that after you lyse the thrombus completely, I found the iliac vein nearly totally occluded with collaterals. So if the lesion, the occlusive lesion, is the cause of the DVT, if you don't treat the lesion, you'd expect the DVT to recur. So I think in some cases where the iliac vein stenosis is really severe, even in the acute setup, I think it's justifiable to put a stent. But the condition, the essential condition for this stent to remain patent is to clear the thrombus completely.
Okay, we have two questions so far. I think one of them was already answered, but I'm going to repeat it. If a patient has from C. Gupta for everybody, if a patient has post-thrombotic iliac vein and great saphenous vein reflux and an active venous ulcer, what would you treat first, Suat and Robbie?
I think I would first treat the occlusive iliac lesion first for the post-thrombotic patients before doing any venous procedure.
So I think I come around the other way on this one. So we would treat the superficial reflux first, and that is as much a reflection of the cost differences. So it is relatively significantly cheaper for us to treat the superficial disease in India than it is to look at doing a PTS reconstruction.
What about plethysmography for these patients?
So that's something we don't have. So we are running purely on anatomical imaging at this point.
And will make a difference post-thrombotic vein and GSV reflux could be totally separate from one end to another end, because you could have a very small 1 centimeter venous ulcer with not huge swelling in the leg and minimal pigmentation, and you could have a 20 centimeter venous ulcer, and also make a decision on the basis of iliac occlusion. So you could have only a 4 centimeter iliac occlusion, or you could have a very severe iliac occlusion within, deep venous SFV also occluded. Because I personally feel that both things has to be included, because sometimes you get a very easy iliac lesion and a mild reflux and a small venous ulcer, then your pattern will change as compared to if you have a very bad deep venous reconstructible iliac veins and a big leg, and where doing a deep venous intervention may not be very easy, and then you will treat the superficial venous reflux first, and vice versa. So I think a lot of things will come into picture before we make a decision.
Individualize the patient. Okay, yes. So from Devendra, post-lysis IV is not opened and ballooning also fails, but has very large collateral flow. Should we accept it? Did you understand the question?
Yes,
yeah. Swat, can you answer, and then after Robbie?
I just try to read from those chat box. I think if the inferior caval vein is not cleared up, and I think we shouldn't accept this as normal. So we should try to open it up. As Dr. Rashad Bishara said that because sometimes we have some acute thrombus or acute DVT on chronic situations. So for those patients, even you end up with a good result as long as you don't stand for those patients sometimes, which is an example of this question. I think you should stent those central veins before. I think it's not good enough to accept such big collaterals because, as you know from Dr. Raju's concept, no collaterals is enough, or can be in, let's say, it can be enough, or can be a substitute of an.
Okay, Robbie?
Yeah, I would agree with that. And I think this is the same thing that Dr. Rashad was talking about over there, that when you're doing a DVT management, you have to individualize the patient. So if you've gone ahead to open it up and you've not been able to recanalize or adequately clear the CIV and or the external iliac vein, and it's not staying open without angioplasty, a stent is required. And that's the fair thing. And yes, the same principle that Dr. Raju talks about, a flow in a vessel is related to the fourth part of its diameter. So to replace a 16 millimeter vein, you require, I think, 1,600 collaterals to do that. So, I mean, a collateral of 5 millimeters is providing flow that is probably 1/20th of what a 16 millimeter vein would be providing. So a big collateral is not good enough. You would need to open up the main channel.
Okay, any other question for the panelists or for the speakers? We don't have any more questions from the chat.
And Swat, can I just ask one question?
Of course.
If you are putting in May Turner's, you're treating a May Turner's and you're putting in a stent, for how long you normally carry the anticoagulations or antiplatelets?
Yeah, Rahul, according to the published literature, it is mostly advised that 6 months anticoagulation is accepted enough, and then antiplatelet therapy should be continued for those patients, since we don't have any problem with inflow for these patients. But there is really very conflicting anticoagulation protocols related with this. When you look at the literature, there are also results with the NOACs. But what I do, because in Turkey, for the May Turner patients, we cannot prescribe NOACs because it is only reimbursed in the deep venous thrombosis situation. That's why I have to use the vitamin K antagonist 6 months, and then I go on with the antiplatelet therapy with aspirin. So this is my protocol.
And if you're treating the post-thrombotic, then?
Yeah, for the post-thrombotic patients, I have now in my cohort, I have some patients with the NOACs, because when I question my patients, especially since you know that those patients are really coming from, especially for the chronic patients, they know that if they are, let's say, INR levels is good with the vitamin K antagonist, if I learn that they have bad experiences with INR, I just directly go with the NOACs. And in my practice, I use mainly twice daily apixaban. This is my protocol. And if I learn that they have good INR scores previously, I go with the vitamin K antagonist, and I keep my INR levels around 3. And at least I am using for one year with the post-thrombotic patients. And if the patients has multiple, let's say, DVT episodes previously before stenting, I go also a lifelong anticoagulation. And if the patient has some thrombophilic patterns, I go for lifelong anticoagulant vitamin K therapy anticoagulation.
Another question, Robbie.
Mm-hmm.
Hi. Yeah. Do we know from the histological studies how much time it takes for the stents in the venous system to endothelize?
So good question. So I don't know the scientific answer to that, but certainly, so I was looking at why do you get a contralateral iliac vein thrombosis when you put in a stent for May Turner? So, Dr. Raju's original plan was, when you put in a stent, it goes well into the IVC, and more often than not, you're partially covering the contralateral iliac vein outflow. So in that context, I was looking at this. And there was this very interesting paper with some images from Peter Glowitsky, which they had to operate on a patient who developed a contralateral DVT with a stent. When they've taken out the stent, you can actually see a complete meshwork of endothelium, which mimics the stent struts, completely covering the contralateral iliac vein orifice. And if you look at the literature, so it's probably at about, sorry, the light's just gone off here. At about 3 to 4 years, you're seeing about a 4 to 5% incidence of contralateral DVT. So that is the time when the endothelium has grown in through the struts and occluded it. So I would presume you're looking at that the endothelial growth is probably kind of finishing by that point of time. So you're getting NIH that's happening at about 4 years point of time.
Dear Rahul, maybe I can give you an answer for this. Because we recently submit our animal study to European Journal of Vascular and Endovascular Surgery, and we made an animal study for endothelialization. And in this study, we use different patterns of stent with different mesh patterns. And the one stent company, I don't want to give it name, produced some special stents for us. Just for this animal study, and this shown that if the stent has, let's say, more than 5 millimeter gaps, especially for the mesh, it is becoming more easy to endothelize, and nearly it starts, endothelialization starts after 1 month, and at our group of sheep, we work on sheep because it is much more easy to make anticoagulation. The pigs, is highly thrombogenic animals, so it is difficult to anticoagulate them. And with, let's say, stent pattern, which has more than 5 millimeter stent gaps, is becoming highly endothelialized quickly, and nearly at 6 weeks time, the endothelium is covering the stents if you have such type of stents. And I think if it is accepted, maybe we can see this animal study soon. And we even make the electromagnetic, electron microscopic also analysis. So it is, I think, one of them will be an valuable article in this issue.
Thank you, Scott. That's a good work. Because why I put in all these questions is, you see, that will, because unless we understand the basics in the veins, because it's either the blood or the metal or the external compression. So depending upon these three things, we decide how much anticoagulation we need to continue in these patients.
Yeah.
So, once we understand the very basics and the pathophysiology, then it may be easier for us to make a decision, because still there are no articles, no protocols, exact protocols, what we should follow,
Yeah. Yeah, as you highlighted, it is not only related with the patient, because it's also related with the stent we use. I can talk from the study that we did on the animal study. But also one of the important issue is, for example, if you make a kissing stent, and for the kissing parts of the stents, the touching metallic parts, it is also very difficult to endothelize. So if we, for example, for the iliocaval patients, when you make such type of stenting, those parts will staying, let's say, safe from, let's say, endothelize free, maybe I can talk, but that's why those parts are still staying as highly thrombogenic, and that's why I think you should keep on having anticoagulate those patients with high level of anticoagulation, and maybe lifelong anticoagulation should be choose for those patients.
Yeah, that's a very very I didn't know about this concept. This is very interesting. Yeah, great. Thank you. I think Dr. Rashid, we can close it. If before we close it, I just want to put in one point from VAI that on 29th of August, in association with Colombian Society of Phlebology, we are doing an international program on lymphedema and the bandages and compression with the world experts. So we'll send you the notification in 1 or 2 days. And if all of you, anybody is interested in getting a very good results with compression in lymphedema, so please attend that webinar. So thank you, everybody. And Professor Rashad, I'll, thank you all the speakers and all the chairpersons and the panelists for joining us and be part of the VR.
Thank you so much, Rahul. It was a pleasure.
Thank you for the kind invitation.
Thank you,
Nice meeting
Rahul.
you all.
Thank you, Swat,
Thank you.
Rashid,